Yeah, so today we'll be starting with the disorders, with the other disorders of sexual development. So this includes the 46XX sexual development issue, 46XY sex development disorder, and the ovotesticular sex development disorder. So they are also known as they are previously known as the intersex um, states. And the main problem here is just when you have discrepancy between the chromosomal sex, that is, what you have in terms of the X chromosome or Y chromosome, the testes or the ovaries, and the phenotypic sex, that is what the external genitalia is saying. So you might see somebody that has a Y chromosome that has testes, and the person is showing features of external genitalia and confirming that of a female, maybe presence of labia majora, clitoris, and all those things. So that's like a discrepancy. So let's go to the first one, the 46XX sex disorder. So in this kind of person, because of the fact that this person is having the excess chromosome, which is in keeping with that of a female, the ovaries will be present, just like we've said. Ovaries will be present automatically, but this individual will have an external genitalia that will look like that of a male, and we call that virilization. So it will be atypical because it is not that of a female, and we can say it's virilized because it's that of a male. So what can explain this kind of presentation? A female that is chromosomally female, XS chromosome, but is exposed to high testosterone, maybe from congenital adrenal hyperplasia. You guys know individuals with the 11 beta and the 21 hydroxylase deficiency, they are not able to produce the glucocorticoid and the mineralocorticoid. So they have abundance of all these precursors being channeled towards the the androgen pathway. So they have high exposure to androgen, and this can explain the discrepancy that they have in their sexual presentation. Then the next one is the 46XY sex chromosomal disorder, sex development disorder. So what happens here? XY, there will be testes that will be present, but when you check the external genitalia, it will not appear like that of a male. It will be feminized or atypical. So what can happen if this person has androgen insensitive syndrome? That is, all the androgens that are supposed to drive the development of the internal dot as well as the external genitalia are not, the receptors are not responding to the effect of the androgen. You can have this kind of presentation. So you expect someone with the 46XY sex development disorder to have normal testes, although in some instances you might not find the testes in the scrotum. You might not even find the person having a scrotum. The person might actually have a labia majora because you don't have androgens to stimulate the external genitalia towards development of the scrotum. So the labioscrotal swelling are going to open as that of a labia majora because there is poor response to androgen stimulation due to the androgen insensitivity syndrome that is happening. So this person will have the testes, but the internal dot will not develop in the pathway of the seed. So you not have seminal vesicles, they will not have epididymis, no ejaculatory duct, and of course the scrotum will not even develop. The prostate will not develop because they need androgen in form of dihydrotestosterone to drive that development. So people with the ovotesticular sexual development disorders, they can have any of the phenotype. 46.
Dr. Babawale, Oya, sorry, Oya, wait. Dr. Babawale, Oya, wait, Oya, wait, Oya, wait, Oya, wait, Oya, wait.
Hello?
Oya, wait. Can you hear me?
Yes, I can hear you. Yes, I can. I
Okay.
can.
Sorry. So this one is, we can call these syndromes androgen insensitivity syndromes, right?
Yes, this 46XY.
Because, okay.
Do you understand? This 46.
46XY is androgen insensitivity. So there is the Y there, the testis is there, but
Mhm.
the external genitalia are not responding to the Y chromosome, right? So we are still having the female external genitalia.
Yes,
So
you
are
get
we
it.
saying something is wrong with DHT? So DHT is not being able to stimulate the external genitalia to develop.
Exactly, exactly. That is a
Okay. So
problem
that
here.
is for the 46XY DSD.
Yes. Before you can say someone
Okay.
has a DSD, you must have a condition that can cause a disparity between the gonads, what the gonads are saying, and what the external genitalia are saying.
Okay.
That is primarily what you are looking. You are not even looking at the internal dot. You are looking at the external genitalia, because you know that external genitalia is what you can see. You cannot see the internal dot. But if you look at a newborn, you can see the external genitalia. So that is what you use to do your own objective assessment. But
Okay.
you will now go
Okay.
and do your your karyotyping to know what the chromosome are actually saying. So if you have a disparity in that, you know that this is likely to be a sex development disorder. Do you get it, Dr. Luatobi?
Oh,
So
it's getting clearer.
so for
So,
46
okay,
for
I'm with you.
46XX DSD now, what is happening is that you have someone that has an ovary because the person is having XX. You know that we have said it. It
Mm-hmm.
is the
Mm-hmm.
chromosome that is deciding what the gonads will produce.
Yeah. Yeah.
XS, that means
Yeah.
this person have ovaries. So the next thing for you to make 46XX DSD means that the external genitalia is not that of the female. That means they are virilized or they are differentiated to that of the male.
Okay.
So what can cause differentiation to that of the male? If they are exposed to testosterone or androgens.
Testosterone.
Androgens.
Yeah.
Do
So
you get it?
females exposed to testosterone is the 46XS
Exactly.
Okay. Okay.
So for the 46XY, it means that there's a male, the testes are there. But when you are looking at the external genitalia, they are not forming penis or scrotum. That means that the androgens that are supposed to drive that um, development are not actually, maybe they are not there, or the receptors are not responding to them. Do you
Yeah.
understand?
Thank
So
you.
so here now,
So I think I
the
get it
commonest
now.
form is that the androgens receptor are not responding. We'll still talk about androgen insensitivity syndrome as we go along
Hmm.
the class. So
Then in this case, can they have like if they have blind ending uterus, that changes it from this DSD, right? It's no longer DSD.
no,
It's
no,
going
no.
to be a Müllerian defect, right?
Blind ending. I don't understand. Blind
Like
and the
blind
person is having
ending
testes.
uterus.
And the person is having testes.
No. Having ovaries.
No, no, no. That's not a DSD. Because
That won't
see,
be a DSD again.
mhm,
Okay.
do you get it?
Okay.
Because
That
you
will
are
be a
having
Mullerian issue. That will
exactly,
be a
that's another thing entirely.
paramesonephric issue. All
That's
right.
another thing.
All
So you have
right.
to look
All
at the
right.
gonads and as well as the other things. And again, the other things I'm talking about, precisely I'm talking about the external genitalia, not even the internal, external. Mm? External and the gonad. External and the gonad. That's what we are looking at.
External and the gonads. The
Uterus is
external
internal.
and the gonads. Okay. Yeah.
Uterus is
Yeah.
internal.
Yeah. Yeah.
So just use the concept of what are you appreciating? External genitalia. You cannot see the uterus. You can only see external genitalia. So what should be the major thing? What should be the major thing that the person should have that is always constant? Is not even the internal dot, because something can happen to that internal dot. But what will always develop is the gonad, because that one always responds to the chromosome. So
Yes. Yes. Yes.
so
Yes.
so
Yes.
once you
Yes.
see,
Yes. Yes.
okay, um scrotum is formed, I expect this person to have a chromosome of XY. If you now do the chromosome analysis, you are now seeing XX. You know that is a likely to be a DSD. 46XS is a
Mm-hmm.
DSD. Do you get it?
Okay. Yeah.
So
Thank you very much.
mhm. So people with the ovotesticular DSD, they can be either 46XX or 46XY. So they can be males or they can be female, but most commonly it's actually with females. And what are you going to see for you to call it ovotesticular DSD? You are going to see both ovarian and testicular tissue being present in one person. So there are too many postulations for this, and of course the genitalia will be atypical. You can see some part that will be looking at that of female and some part that will be looking at that of the male. You can't really say that this is, maybe you can see a small phallus, and of course you see that the maybe you see something that looks like labia minora or something, and you are confirmed, you are seeing the disparities. You are seeing some male component, you are seeing some female component. You cannot really place where that person is standing. So, and you check you gonads, you're able to appreciate both ovarian and testicular tissue, then you following your biopsy, so you can say that this is a case of ovotesticular DSD. So there are so many postulations on how this one can happen, but I don't think they can really test that because it's very complex. So some studies have shown that maybe it's due to mutation in the XRY gene in especially in people with 46XY, or some will say that it's due to the fact that maybe you have one two eggs fertilized by two sperm and they are fused together to form one zygote. So that zygote now contains they form two zygote actually. The two zygote now fuses together to form one individual, which is now containing both ovary and testicular tube. But I don't think we should really worry ourselves about that. Once you see a question that is painting towards presence of two different conates, the testes, the ovary, you already know that they are talking about ovotesticular, DSD. It's very straightforward. I know that this one is too straightforward. They might not likely ask us. What you just need to remember here is that it is commonly shared with individual of the 46XX. But these ones are the ones that can be confusing that you really need to understand. The 46XX DSD and the 46XY DSD. Okay. So let us go to how you want to diagnose individual with disorders of sex hormone. So um sometimes you can have some laboratory pictures like this that will show you and they will tell you to interpret it. So if someone has elevated testosterone and elevated LH, this is likely to be androgen insensitivity syndrome, because what happens in androgen insensitivity is that the testosterone are present, your DHT is present, they are acting on the androgen receptor, but the androgen receptors are not responding. So of course, level of LH2 is going to be high because LH will try to the hypothalamus or the pituitary gland is going to see it as if that okay, you don't have enough testosterone to actually stimulate the receptor. That is why they are not responding. So they try to increase the production of the anterior pituitary gland, and the hypothalamus will try to stimulate the anterior pituitary gland to release more LH, and the LH will try to stimulate the gonad to produce more testosterone up to no effect, even without any eventual effect, because the problem is actually with the receptors. So you are going to observe elevation of both the testosterone and the LH. So if the clinical picture you have is increase, because the feedback mechanism is actually going to be lost here. You don't have any inhibitory feedback mechanism here. But if you see a picture of increased testosterone and decreased LH, that means that the problem is actually coming from, you know, um, increased testosterone production. So here, the negative feedback mechanism is still preserved. So you have high testosterone, being present either exogenously or from the gonad itself, and it still maintain the negative feedback mechanism, suppressing the production of LH from the anterior pituitary gland. So what are the things that can elevate the level of testosterone without actually elevating level of LH? So testosterone secreting tumor. It can be autonomically discharging testosterone that can inhibit the level of LH by the feedback mechanism, or this person is taking anabolic androgenic steroids exogenously, which can also present that way. So the next one is where you have a reduced level of testosterone and increased level of LH. There's reduced level of testosterone but increased level of LH. So it means that um, here the problem is actually from the gonads. The gonads have failed to produce testosterone, and the inhibitory effect on the anterior pituitary gland is not there. So the anterior pituitary gland will try to work hard more to stimulate the gonad to produce more of the LH. That is why you're having elevation of LH. So this can happen when you have hypergonadotropic hypogonadism. Let's say that this person um you know, suffered mump orchitis that damaged the testes, and the level of production of testosterone falls. This is what you are going to have. Level of LH is going to rise correspondingly in response to that. Maybe the person have bilateral acutectomy and they remove the testes. It can present similarly. So what's the last one? Reduce testosterone, reduce LH. Reduce testosterone, reduce LH. So that means that the problem is actually coming from up. This upper stimulation is not there. Anterior pituitary gland stimulation is not there. And of course, if you don't have stimulation of the anterior pituitary gland, you cannot have a downstream production of your testosterone from the gonads. So that is the case of hypogonadotropic hypogonadism. An example of this is what we talked about in Kamal syndrome. So someone that has Kamal syndrome and the person doesn't have production of the GnRH releasing neurons. So there's no production of GnRH, there's no production of LH, and there's no production of testosterone. Or this person has a CNS lesion damage to the hypothalamus or the anterior pituitary gland, you can have this picture. Do we get it, or we have any question here? Okay, so let's go to disorders of physical characteristics. Disorder of physical characteristics. So this is what you are seeing. These are the pictures that you are seeing. So someone with uterus without breast. You see an individual with uterus without breast. What stimulates the development of the uterus? So that means that the Mullerian ducts are actually there. That's what brings about it. But there's no estrogen, you know, to stimulate development of the breast. So that is in keeping with someone that has hypogonadism and the person is a genotypically female, because you cannot have an individual that is genotypically male having uterus. It's not possible. It is not possible. Once you are genotypically male and you are producing your testes and you are releasing AMH from the Sertoli cell, the paramesonephric duct will automatically degenerate. And in the absence of the SRY gene, in the absence of testes, the paramesonephric duct develops by default. I failed to mention that. So you don't even need any stimulus to stimulate development of a paramesonephric duct. Once there's absence of testes, it develops by itself. It doesn't need any stimulation. So that is why when you see someone that has uterus, you know that automatically this guy is a chromosomally or genotypically female. But breast is part of what we talked about to be the secondary sexual characteristics. And I told us then that the facial and the pubic hair is under testosterone, but the breast particularly is under estrogen. And the hormone that you expect someone that is a female to release is estrogen, not testosterone. So if this person is not having high amount of estrogen that is required, maybe from any cause of hypogonadism, this person is going to present this way. So someone that has hypogonadism either from problem with the pituitary or the hypothalamus, they are going to have hypogonadotropic hypogonadism. Someone that has maybe removal of the ovaries or radiative damage or chemotherapy damage to the ovaries, chemotherapy of ovaritis or something, there's damage to the ovaries due to chemotherapy exposure or radiation exposure or infection or any cause, maybe removal from surgery, surgical removal, they can have hypergonadotropic hypogonadism because your anterior pituitary gland will still keep stimulating the gonad by releasing FSH and LH. So you are going to have elevated levels of them. But the bottom line here is that estrogen is reduced. So you are going to look for anything that can explain reduced estrogen, which is hypogonadism. Yeah. So there's no uterus and there's breast. So this one can come in both male and female. Okay, there's no uterus but there's breast. Let's look at the female component. This person can be a female. Okay, it can be a female because the uterus is not developing. Yes, but that means that there is likely of a problem with the mesonephric duct, with the paramesonephric duct, the Mullerian duct. The Mullerian duct is not developing. That's why they are having absent uterus. So if this guy is genotypically female and there is Mullerian agenesis, the person will not have uterus, but the person can have breast because breast is actually coming from the ovaries. Breast development is due to ovarian stimulation by production of estrogen. So if this person is genotypically female and has Mullerian agenesis, all the internal ducts will not develop, including the uterus, but the breast will develop because the ovaries are intact. Okay, that's for the female. Now, this person can also be a male. What if this person has something like okay, androgen insensitivity syndrome is one situation. Of course, in a genetically male, you don't expect a genetically male individual to have uterus, so uterus is not there. But you expect them to, not to develop breast because they don't have high estrogen. Testosterone doesn't stimulate breast development. But if they have androgen insensitivity syndrome and you know the the um the testosterone that is present is not being responded to, majority of the testosterone will be converted to estrogen. That is why in individual with androgen insensitivity syndrome, you are seeing high LH, high testosterone, and high estrogen. That's a picture, that's a laboratory picture. All these testosterone that are accumulating, that the tissues are not responding to, they keep accumulating and they are going to undergo aromatization in the Sertoli cells to produce estrogen. So that estrogen effect on the breast, regardless of your gender, if you are male or female, once estrogen finds its way to stimulate your breast, it's going to cause gynecomastia. So one of the ways by which you can have absent breast in an individual, absent uterus and presence of breast in an individual that is male is androgen insensitivity syndrome. Another possibility is maybe someone that has Klinefelter syndrome. You guys remember that in Klinefelter syndrome there is presence of breast and there's no uterus. Hmm? There's no breast and because of the fact that these guys don't have testosterone in them. So there's unopposed action of estrogen, the little estrogen that they are producing maybe from the adrenal gland and all those things that brings about the gynecomastia that they experience. So, but the classic presentation is usually very much in keeping with androgen insensitivity syndrome. Okay, so um, the next one is aromatic deficiency. So this one we just need to be able to explain how the presentation is. The function of aromatase is what? To convert testosterone to estrogen. Conversion of androgens rather to estrogen. Androgens to estrogen. And it usually takes place within the adrenal gland, the testes, and other things. That's for male. But in fetal life, that is after development, guys. That's after development. In fetal life, the placenta needs to also produce its own estrogen and progesterone, particularly estrogen. How does it achieve that? The adrenal gland produces androgens, particularly DHEA, that's the dehydroepiandrosterone. That is what the fetal adrenal gland produces. This DHTA is going to be released, into the fetal blood and is going to be taken to the placenta. And the placenta will use its own aromatase enzyme to convert it to estrogen. Which estrogen is the placenta going to take it to? Anybody?
No,
Hello? Hello? What are the forms of estrogen that we remember?
estradiol, and estriol.
Okay, so which one is coming from the placenta?
Estra, estriol.
Yeah, so the estriol, that's the least potent one.
I'm correct.
So the most potent one is the
I'm
2.
trying to.
The most potent one
Yeah,
is the 2. That's estradiol. That's one that's coming from the ovaries. The single one,
the ovaries. Okay.
the single one which is estrone, that's the one that is coming from the adrenal
Estriol.
gland. Why the
Okay.
triple one,
Okay.
which is estriol, is one that is coming from the placenta.
Center.
That is one that is
Okay.
increased by 1,000-fold in pregnancy that used to monitor the fetal well-being. So during fetal life, before maturation, before birth or delivery, the placenta needs to produce estrogen too. So how does it get it? The adrenal gland in the fetus produce the dehydroepiandrosterone that is going to get converted to estriol by the placenta. And it can be converted to testosterone also peripherally by the adrenal glands that are in the fetus. So now, if someone has an aromatase deficiency, so that means that this DHA, that is this DHEA that is being produced by the fetal adrenal gland cannot be converted to estrogen. So you have a lot of DHEA in circulation. Mm. So they are going to find their way back to the adrenal gland and they are going to be converted to testosterone. So you have high testosterone load in the fetus. So because of the fact that fetal blood also finds a way through the umbilical vessels back to the placenta and the like. So eventually you are going to have hormones, the testosterone being released back into the maternal circulation. So is the high testosterone that is from the conversion of DHA to testosterone is going to act on the mother and it's going to cause virilization of the mother. So what do you see? We know that testosterone stimulates sebaceous gland secretions. There will be acne. It promotes hair development, facial hair development, hirsutism. And again, even on the fetus again, especially if that fetus is now male, it's going to virilize that infant and allow its external genitalia to develop towards that of you know if a male infant. Sorry, I said if the person is male. If the infant is female, you know, female that is exposed to high amount of androgen is going to differentiate towards the male you know differentiation pattern. So you are going to have a female that's supposed to be having clitoris, labia majora, labia minora, having fusion of the fold to form a penis and You can see the penis, you can see the scrotum. So that's what you have in someone that has aromatic deficiency, because the um the DHEA that's produced from the adrenal gland of the fetus is not being converted to estrogen, by the placenta. So that means you have a lot of DHEA being converted to testosterone by the fetal adrenal glands, and they are going to cross the placenta to the mother side. So higher testosterone exposure in the mother brings about virilization, which includes acne, hirsutism, and also virilization of the female lymphat, bringing about formation of testes, formation of scrotum and penis, in a female lymphat. So once you see that in a question, you know that they are talking about aromatase deficiency. So we are back
So
to
can it, in a guy, Dr. Babale, in a guy, will it cause precocious puberty in them
no, no, no,
from the womb?
it would, because
Like,
that's what you're
will it cause any testicular hypertrophy or
no,
any
no, no. That's what
hyperstimulation symptom in them?
that's what they
Okay.
think. So it's only the mother. It's only the mother that will be, suffering that problem. That's
Okay. 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 Okay.
so yes. So androgen insensitivity syndrome. Androgen insensitivity syndrome. It's just a problem like I've mentioned before with the androgen receptor. So that means that there's an innate problem with the androgen receptor signaling pathway that is not allowing it to respond to androgen stimulation. So the that presentation can be best appreciated in a guy, because it is a male that actually needs androgen to develop. So what happens, the person is genetically male, that is, person has the 46XY chromosome. You can see it, they have already called it 46XY DSD, because of the fact that the external genitalia of that person, even the internal genitalia, but let me leave the internal genitalia and I will go back to that. The external genitalia of that person will not differentiate along the pattern of the male. Why? Because you need DHT to stimulate the external genitalia, to develop that of a male before puberty in someone that is genetically male. So the person is going to have a female external genitalia. And of course, you guys remember that testosterone is also involved in the formation of the pubic and the axillary hair. So it's going to be scanty. And of course, this person is a male. The internal genitalia will not just develop into the seminal vesicle, the epididymis, and the ductus deferens. It's not as if it should differentiate into that of the uterus, because of
Is
course.
it just me or can everybody hear Dr. Babale? Dr. Shala?
I
Hello?
can hear you.
The first one. It's not breaking from here in Davi.
Hello?
No, it's not breaking.
Can hear you.
Hello?
Please.
Hello?
Hello.
Yes, yes. Is Dr.
Hello.
Oluwatobi having
Yeah.
issues with the network?
I
I
think she
think
said
my
her network
network
is
is
breaking.
breaking. Like it's pausing. Yeah.
Oh,
Yeah, and I was also saying that maybe can you reduce like the speed
But
at which you're
since
delivering?
it's just me.
okay. Okay, yeah. So let's just take it. So Dr. Oluwatobi, what about now? Is it better now?
Yes, I'm fine now. I'm fine.
Okay,
Thank you.
yes. So Dr. Julius was saying something.
Yes, I was saying that can you reduce like your speed of delivering? Maybe she like
Okay, all right.
yeah, thank you.
So someone with androgen insensitivity syndrome, the problem in that person is that they are producing androgens, but the androgen receptor are not responding to those androgens that are being released. Okay. And I said that androgen is essentially involved in development of the, external genitalia, particularly DHT, and also in the development of the internal genitalia. So, how would this person present? The most common incidence is actually in the males. So, what you just notice that the person is going to be genetically male. That is, if you do the cryoanalysis, you are going to see 46XY. But what you see outside will not be in keeping with that of what you expect in a male. So you are not going to see the normal penis enlargement, you are not going to see scrotum. So what you are just going to see is just fold of tissue that fails to close, like the labia majora, the labia minora, and a very, very short, you know, derivative of the genital tubercle, which you can call the clitoris. All those things will be rudimentary. And of course, because the person is a male, you do not expect the person to have uterus. So there will be absence of uterus, because you know that when you see someone that is having formation of clitoris, formation of labia majora and minora, you expect that this person should have internal duct derivative, which is in keeping with that of a female, that is uterus and fallopian tube. But you will not see that because the person is actually chromosomally male. And because the person is chromosomally male, the person will have produced, the testes that will contain Sertoli cell and the Leydig cells. So the Sertoli cells will have released the AMH, that's the anti-Mullerian hormone, that will have caused the paromesonephrine duct to degenerate. So automatically the person will not have uterus, the person will not have fallopian tube, the person will not have cervix. Upper part of the vagina will not develop. But because of the fact that, okay, it's possible that the lower because the lower part of the vagina comes from the urogenital sinus. So you can actually have failure of development of that. It's not as if it will not develop, but it will be very rudimentary because it's coming from the urogenital sinus. So you just see rudimentary vagina in that person, but you not see uterus, you not see fallopian tubes, you not see cervix. And if you look at the external genitalia, it's going to be like that of the female because there's no DHT to stimulate the indifferent external genitalia to develop into that of the male. And if you observe them for other secondary sexual characteristics, they are going to be absent. There'll be scanty axillary hair and there'll be scanty pubic hair because of the absence of DHT stimulating those hair follicles. So that individual can actually have even undescended testes, number one, or if the testis is even going to descend, it's not going to descend into a scrotum because there's no scrotum that will form. Scrotum is the external genitalia. They will form labia majora, and you are going to see testes which are functioning because of the fact that this guy is XY. That one, the person will actually form testes, but you are going to find that testes within the labia majora. And abnormal testes like that, labia majora that's exposed to the external area, you know, that there's high risk of that testis developing into a malignancy. So that's one of those things that they can test. So once you see testis in an abnormal position, maybe in the inguinal region, in the abdomen, the labia majora, you want to remove it in order to reduce the risk of developing malignancy. So how will this person present? Because of the fact that it is a receptor problem, the body will want to try to load all the forces it can load to overcome that resistance. It's going to try to increase the amount of LH, even GnRH, LH, testosterone level, all of them are going to be high. And because of the fact that you have high testosterone being produced, there's increased testosterone to estrogen. So I can say that the estrogen stimulation can explain why you have this rudimentary vagina, in which the lower aspect of the vagina that is coming from the urogenital sinus, yes, can undergo the estrogenic stimulation and it will develop into something that looks like a rudimentary vagina. So that is that about androgenesis. So once you paint a scenario like this, they can paint this scenario like this. They'll just tell you the person doesn't have uterus, he doesn't have fallopian tube, and the person has testes. They might not even tell you that the person is XY. They will not put it there. They will just tell you that the person has testes. And they can also tell you that they find the testes maybe within some structure that look like the labia majora. So the next thing is, what is the mechanism of this disorder? So all what you just need to look for in the answer is just something that is in keeping with receptor resistance or androgen insensitivity. That is what you need to look out for. So this person will be looking like a female outwards, but internally the person is a male because the person has testes, which is in keeping what you expect in someone that has XY, you know, gonads. So let's look at the last one. The next one rather, 5-alpha reductase development deficiency. So 5-alpha reductase deficiency, it's an autosomal recessive condition. So it's also limited to 46XY, just like our androgen insensitivity syndrome. And the problem here is just inability to convert testosterone to DHT, because 5-alpha reductase is what you need to convert testosterone to DHT. So that person is going to have atypical genitalia until puberty. Beyond puberty, everything starts getting to normal. So when they give birth to this person, he's going to have some external genitalia structure that is, looking like that of a female. You're going to see labia majora, labia minora, but testosterone is actually there that is working. So all the internal dots are going to differentiate towards that of what you expect for a male. So because DHT is not what is driving internal dot differentiation in male, so testosterone is what is driving that. So the seminal vesicles, the epididymis, everything, they are going to form, but within that time you are going to see ambiguous genitalia, short, clitoris, absence of scrotum, labia majora, labia minora is going to be what you are going to see. Then once puberty is reached and testosterone is one that takes control over development of external genitalia, everything starts normalizing. So you begin to experience masculinization of that individual. All those feminine features that are present will be absent. Broadened chest, deep voice, and all those things begin to manifest. And there's increased growth of the external genitalia towards that of the male pattern. So that is a typical presentation of someone that has 5-alpha reductase deficiency. So the level of testosterone and estrogen is usually normal, because it's not a problem of testosterone or estrogen, but it's a problem of production of DHT. So the level of LH2 can be normal, but if the DHT level is very, very low, LH production can increase in order to, drive production of more DHT, which is not actually going to solve the problem, because there's no enzyme to produce that DHT, and the internal genitalia in that kind of person is normal. Very, very important. Unlike what you have in androgen insensitivity, you don't have any internal genitalia that has been formed. External genitalia is ambiguous. So, but in 5-alpha reductase deficiency, the internal genitalia is normal. It's just the external genitalia that is abnormal temporarily. Then once puberty is achieved and testosterone is what is driving that development of external genitalia, the problem resolves. It is autosomal recessive. One way you can know is that whenever you see any genetic condition that is affecting an enzyme, they are always autosomal recessive. Always autosomal. Most of the time, they are autosomal recessive. Once an enzyme is involved, autosomal recessive. Okay, then the last one,
Dr.
Kamansi.
Babali, sorry to take you back. Oh, it has scattered in my head.
Okay,
Androgen insensitivity
okay.
means both testosterone and DHT. Abi?
Hello, you said what? Hello?
Babali, can you hear me?
Yes, I can hear you. I can hear you. Hello? Hello? Can you guys hear me? Anybody?
External genitalia is still not forming.
Okay, yes, I can hear
Do
you
you
now,
get?
Dr. Latobi. I can hear you now.
I'm saying for this androgen insensitivity,
Mm-hmm.
that means both testosterone and DHT are having issues. The
Yes.
body is not answering it.
Yes.
That's why we don't, even though we have the testers,
Okay.
we don't, because I'm wondering why we still have, oh, okay, so because there's, but if the testosterone is there, why is the AMH still functioning to be causing vagina and uterus to be formed? Okay, it's absent.
No,
Okay, it's
vagina and uterus
absent.
is absent. They are not formed. They are not formed. Hmm?
Okay,
You don't have
thank you.
any
I
internal
think,
genitalia that is there. What you just see is rudimentary vagina. Do you understand? What you
okay,
just see.
so the testis is the male, yeah, the testis is supposed to be the male defining organ. So
Yes.
because it is there, testosterone there is inhibiting the female internal genitalia from being formed. Okay,
No, no, no,
okay.
no. Let me say it well. Let me say it well. This person is a 46XY. is a male, right? Dr. Luatobi is a male.
It's a boy, yes.
Now,
Yes,
because
yes.
he's a male, he's going to release it's going to form Leydig cells and Sertoli cell. You remember that. So,
Yes.
what does Sertoli cell release? Hmm? What does it release?
LH.
Sertoli cell, Sertoli,
AMH.
AMH. So, when it releases AMH, what will happen to the paramesonephic dot? They will not develop. You will not have uterus, fallopian tube, and upper vagina. You guys know that upper vagina is coming from paramesonephic dot. You guys
Is
remember?
AMH MIF?
Yes, AMH is MIF.
Okay, okay.
So, upper vagina is not formed. Uterus is not formed. Fallopian tube are not formed.
Mm.
So, what is supposed to form? What is supposed to form? What is supposed to form? The mesonephric duct, right? But the mesonephric duct at the same time also requires testosterone to develop. Do you guys get it?
Mm-hmm.
The mesonephric
Mm-hmm.
duct too will not develop because this person is having androgen insensitivity. They will not respond to that testosterone. They will not develop. Now,
So even though the testis is producing testosterone, the body is not responding to that testosterone. So the testosterone there is useless.
yes, it is useless.
Okay.
So, why they are having rudimentary vagina is that you guys remember that the lower part of the vagina is coming from where? Hello? Am I still here? Hello?
Yes.
The lower part of vagina
You're
is
still
coming.
here, Dr. Babadi. You're still here.
You guys are not
So
responding.
genital sinus.
Your genital
Sorry,
sinus.
I'm thinking about it. Yes.
So, if it's coming from the genital sinus, you know that that is not part of the
Yeah.
paramesonephic duct. So that means that it will not degenerate.
Yeah.
Do you guys agree with me? It will not degenerate. So that means it
Makes
will actually
sense.
form. But you guys remember that people with androgen insensitivity, they have high testosterone. And that high testosterone is going to undergo aromatization to estrogen. So you have elevated estrogen. That estrogen is going to try and differentiate that one that is coming from the genital sinus to vagina, causing that rudimentary vagina to be the only thing that you are going to see. So you are not going to see any seminal vesicle, you are not going to see any uterus or fallopian tube, you are not going to see anything. Only thing that is there is testes and your rudimentary vagina. And of course, your external genitalia of that of a female. Because what you need to develop external genitalia for a male is DHT, which is absent. So that means that they will just persist as that of a female, causing formation of labia majora, minora, clitoris. So the testes that are supposed to descend into the scrotum will actually descend into the labia majora or not even descend at all. Guys, do you guys get it now?
Yeah.
Hello?
I think I do now. Yes. Thank you.
Okay. So, yes, so let's go to the last one. Kallmann syndrome. So Kallmann syndrome is just like I've said before, I said that the major thing about Kallmann syndrome is that there's absence of migration of your GnRH releasing neuron. This GnRH releasing neuron actually comes from the olfactory placode or olfactory epithelium. So this olfactory placode is just some embryonic structures that develops into the olfactory neurons. So if you don't have formation of these olfactory neurons, you cannot have the olfactory bulb, the olfactory epithelium. So there's no olfactory neurons to allow the process of smell sensation. From these olfactory neurons, it's where your GnRH releasing neuron generates from. And when they form from that olfactory neuron, they are going to migrate, from the olfactory placode rather, they are going to migrate to the hypothalamus. They migrate to the preoptic nucleus of the hypothalamus, where they start performing their own action. So if you don't have formation of your olfactory placode, there's nothing forming the olfactory neuron, the olfactory bulb cannot form, you cannot have formation of a GnRH releasing neuron, and there's no way this person can achieve puberty because GnRH is absent. So that is automatically a case of hypogonadotropic hypogonadism. In addition to this person will also be having problem with smell because the initial problem is failure to form the olfactory placule. So there's hypoxia, there's anoxia. So it depends on the the severity. There can be anosmia or there's just partial loss of smell, hypoxia. And in addition to that, there's going to be failure of pubertal development because of the generate um, neurons are not, general neurons are not formed. So there's no generally releasing hormone. There's no way LH can come into the picture. There's no way FSH can come into the picture. This person will not achieve puberty. If it's a female, the person will not menstruate. The person will not ovulate. If it's a guy, the person will not have development of the secondary sexual characteristics, pubic hair, axillary hair, deep voice, broad shoulder, increased muscle mass. All those things will not be there. And of course, sperm formation too be affected. The male will be infertile, while the female will be amenorrheic, primary amenorrhea in female. In males, primary, azoospermia. Azoospermia that has been, although you don't have primary MBCs, I'm just trying to qualify that as azoospermia. So, do you understand this? I think Kama syndrome is very straightforward. So, it's a cause of hypogonadotropic hypogonadism.
Yeah, any case of hypogonadotropic that they put loss of smell just
Yes,
makes it
easy.
Kalman syndrome. Yeah.
All right. So, yeah, so let's go to the placental disorders. So, the placental disorders, one of them is the placenta accreta spectrum. I know you guys are really familiar with this. So it's just a spectrum of three major disorders: placenta accreta, increta, and pancreta. Placenta increta, accreta, and pancreta. So from mild to severe, accreta is the mildest or the mild, increta is moderate, while pancreta is the severe one. Now, what happens in this condition? This condition is just when you have a morbidly adherent placenta. That is, placenta that is morbidly adherent to the myometrium that is, underlying the endometrium. The myometrium that is just behind the endometrium, when you have a placenta that is adhered to it. And it is actually due to abnormal trophoblastic invasion of that myometrium. So what are the risk factors for this? Anything that can bring about uterine scarring. The way this decidualization of a thing happens is that they try to go to virgin sites, areas that are very, very rich, that are very, very new, that have not been altered at all. So area that are scarred or they have been altered, they want to run away from there. So your decidualization doesn't happen in area of uterine scarring, or there's problem with the decidual layer of the uterus. Maybe it's too thin. When it's too thin, maybe someone has not there and see, and there's thinning of the decidual due to excessive scraping, or there is there's what do I call it now? Or um if this person is actually maybe a multiparous person, a grand multipara, the person has had so many paros experience, you expect some thinning of the endometrium with time, or someone that is of advanced age. You cannot compare the endometrium of someone that is the age of within reproductive years, 20 to 30 years, to someone that is very old, like 50 years and above. And when that happens, your trophoblasts that are formed from the placenta will not see virgin sites or enough decidual area or enough endometrial area to implant to. So they want to penetrate down into the endometrium, and in the process, they are going to reach the myometrium. So once they understand this pathophysiological basis, you can think about the causes. You can think about so many causes. So when we are looking at the aspect of scarring, you can think of maybe previous cesarean section. If this person has done a previous CS, is a cause of uterine scarring. If this person has done a previous D&T, maybe for abortion, maybe this person has had gestational trophoblastic disease and they want to do dilatation and curettage, it can be a cause of uterine scarring. Or maybe thinning of the endometrium, advanced age, like I talked about, or multiple parous experience. All these things can bring about, this placental issue or placenta previa, because for you to even have placenta previa in the first place, that means that there you don't it's possible that you don't have enough virgin sites in the uterus again. That's why the placenta is trying to, because majority of the placenta prefers to adhere to the upper part of the uterus, upper posterior part of the uterus. That's where they go to. But when you have damage in that area, they want to go down and try to see if they can get, they can form very good decidua within the endometrium lying the lower part of the uterus. So a previous placenta previa can even predispose, to these placenta accreta problems. Or someone that have even had placenta previa, the ongoing placenta previa can even, because in the course of trying to find virgin site, it can even start undergoing deeply, adhering deeply to the endometrium in order to get to form very rich decidua, which might not eventually happen because it's entering into the myometrium. So that's why they will say that placenta previa can also be a risk factor for, a morbidly adherent placenta. So what happens in each of these spectrum? So in placenta accreta, you don't invasion of the myometrium. You just have attachment of you know, the placenta towards the myometrium. So this is the placenta being formed here, and this is myometrium. So this is the endometrium layer already being bypassed. So it has covered the endometrium. It's now touching the myometrium. It doesn't invade it, just attaches to its surface. That is a crater. So in crater, it is already invading. So it's invading the myometrium and attaching directly to the myometrium wall. So it's attached to it and invading to it. But for the pancreata, it has attached to it, invaded into it, and even perforated, your myometrium. It's now going outside the serosa. So this is the serosa covering of the uterine wall, or we'll call it the perimetrium. And the structures that are outside the serosa include structures like the bladder of the rectum. Hello? Please, are you guys still hearing me? Hello guys, can you guys still hear me? Hello? Hello?
Hello.
Can you guys still hear?
Yeah.
Oh, I
Okay,
can
okay.
hear you.
So
Yes.
so it's now penetrating the outer serosa, and what you can have in this outer serosa include two things majorly: the bladder and the rectum, depending on the part of the uterus that we are looking at. Let me just try and show you guys an image so that you can picture, the uterus with respect to the bladder and the rectum, so you guys can see what we are talking about. So one of the problems of the so you guys know that this is the endothelial lining. You guys can appreciate that this is the endothelial lining. Now, you having a placenta that's not penetrating deep like this, it can perforate this external serosa that is here and can reach the bladder. Or if it's actually at this area, it can penetrate through this myometrium and reach the rectum on this side. So you can have, invasion of both the bladder and the rectum. So in your pancreata. So so when it enters the bladder, it can cause hematuria. It can cause hematuria because blood will start rushing into the bladder and there will be hematuria. So if it enters into the rectum, there can be, you know, bloody stool too, hematochezia, from invasion into the rectum. So what is one of the most feared complication of your placenta, accretal spectrum? It is what? Postpartum hemorrhage. That is what we are scared of. Because postpartum hemorrhage, one of the causes of postpartum hemorrhage is when you have retained placental tissue. A placenta that is morbidly adherent to the myometrium doesn't readily come off following delivery of the baby. It doesn't follow the delivery of the baby just like that because it has been firmly adherent to the myometrium. So it's either you do a manual removal or you do a surgical exploration in the theater. And before you do that, the person will keep losing blood until you eventually remove that, placenta. So because of the difficulty you experience in separating the placenta from the myometrium in the morbidly adherent placenta spectrum, you can have the person developing postpartum hemorrhage. So that is that about the placental accreta syndrome. So the next one is the placenta previa. So the the placenta previa and the placenta accreta actually works by very similar mechanism. They develop due to very similar mechanism. In placenta previa, you are just saying that you are having the placenta implanting in the lower aspect of the uterus, and it should normally be in the upper aspect. It should normally be here, upper posterior aspect of the uterus. That's where you are supposed to have your placenta implanting. So if you have your placenta implanting somewhere here in the lower segment of the uterus, you call that placenta previa. So because you are not doing step 2 and O and G part of step 2 now, we don't really need to talk about the classification of the placenta previa into major or minor, or type 1 to type 4. So what we just need to know is that when you have placenta being, implanted on the lower aspect of the uterus, that is placenta previa. And what are the risk factors for placenta previa? Just like I've talked about, you know, you want to the placenta is just trying to look for virgin areas to implant to. A mother that is multiparous, giving birth a lot, you begin to have, thinning of the endometrium in that area where the previous pregnancies have implanted to. So it begins to go down to look for virgin area. A previous cesarean section might have caused scarring of the endometrium. So it wants to go downward. Multiple gestation, because there's no space for the fetus to, for the placenta to implant. The fetus are occupying everywhere. So it is possibility of the placenta implanting in the lower aspect in multiple gestation. So, previous D&C, previous history of placenta previa itself, previous dilatation or created for any reason, previous cesarean section, a multiparous experience, increased maternal age, um, smoking, or predisposed to placenta previa. Smoking due to vasoconstriction, vasospasm, reduced blood supply to the uterus, and it begins to look for better blood supply, begins to go down into the uterus. That is one mechanism. So what you have is that you begin to have your placenta invading to the lower aspect of the uterus and can eventually close or cover the internal cervical holes. So the degree or the extent of the coverage of this internal cervical holes now brings us to the classification of the placenta previa, which I'm not actually going to talk about. But it's important for us to know that there's also a phenomenon that's called the low-lying placenta, in which you have the placenta, staying within the lower aspect of the uterus, just within 2 centimeters from the internal horse, but not actually covering the internal horse. So in placenta previa, you actually have covering, you know, if not entirely, but some degree of coverage of the internal horse. But in low-lying placenta, it does not cover the internal horse, but it's just within 2 centimeters from the internal horse. So someone that has placenta previa, how do they present? So it's very, very important for us to remember that someone that has placenta previa actually presents with painless vaginal bleeding at the third trimester. Why? Because initially, during the early part of trimester, the first part, you don't have formation of the lower segment of uterus yet. It's not formed yet. So, and that um placenta has already implanted into the lowermost part of the uterus, even though you have not formed the lower uterus segment, but the lowermost part, that is where your placenta has implanted to. So as the uterus develops and enlarge, with each trimester, it begins to get stretched. So the stretching of the uterus as the uterus grows, the stretching of the uterus and extension of the placenta with development of the uterus as the trimester passes, causing separation of the placental bed, which brings about bleeding, and it's majorly coming from the fetal part. That's why it's painless. The mother doesn't really feel it. So, but it's torrential. So it, comes down, stop later, comes again. So when you see torrential, no, more like, episodic bleeding that is painless that occurs in the third trimester, you know that that is likely to be a case of placenta previa. Hmm? So what is the next one we are talking about? Vasa previa. And we should know that is a very cause of antepartum hemorrhage, that is bleeding before, eventual delivery, before, the age of viability itself. No, after the age of viability, but before delivery. Bleeding before delivery, but after the age of viability. Because if you have bleeding before the age of viability, that's likely to be an abortion process, either incomplete, complete, or you know, threatening abortion. So that is that. So, but when you have bleeding before delivery, that is, antepartum hemorrhage, and one of the causes is placenta previa. Another cause of antepartum hemorrhage is vasa previa. So, what happens in the phenomenon of vasa previa? That one is best explained with an image. So this is what you have in placenta previa. You can see that the placenta is occupying the lower uterine segment and is covering the internal horse. So in the vasa previa, what you're having in the placenta previa is that you are having the presenting part of the uterus of the baby, just lying over the fetal vessels, and that part is also passing over the internal horse of the cervix and is in the lower segment of the cervix. So the fetal vessels are just passing over the internal house within the lower aspect of the cervix, unprotected, unprotected. So what are the two major causes of this presentation? Number one, when you have um so from the name vasa is fetal vessel, previa lower segment. So you have the fetal vessel occupying the lower segment of the uterus with the presenting part directly attaching to it. So what is the cause? And not the placenta now, not necessarily the placenta, but the fetal vessel is the predisposed one now. So what are the two major causes? The first one is filamentous insertion of the umbilical cord into the choroamniotic membrane. So you guys know that here, this surrounding is actually contain the choroamniotic membrane. Is one that surrounds the fetus. Now, the umbilical cord develops from the fetus, the yolk sac of the fetus like that, then is now attaching to the choroamniotic membrane here. It's supposed to move like this and attach directly to the placenta, but here it's not doing that. It's not doing that. It is attaching to the choroamniotic membrane, and that is where you have cessation of formation of a waxing jelly. So that means that the other thing that will just be passing will just be the umbilical vessel. You know that the umbilical cord is different from the umbilical vessel. Umbilical cord is the covering that surrounds the umbilical vessels, you know, which is also from the allantois. It comes from the allantois and the yolk sac. That's where the derivative of your umbilical cord, just like we explained earlier. So if the umbilical cord is now inserting on the choroamniotic membrane, instead of this part inserting in the middle part of the placenta, is now inserting the choroamniotic membrane. We call that filamentous attachment of the umbilical cord. You guys can see here that this umbilical cord is coming from the fetus like this and is inserting into the placenta. No problem. Everything is covered by waxing jelly. But here it is inserting here. So the remaining part is exposed, and they can easily get ruptured. They can easily shear off and you start to have fetal bleeding. Fetal
Hello?
bleeding. Hello? I'm with you,
That's
Doctor.
Baba.
Hello?
Baba, are you sharing your screen?
Yes, I am, Dr. Francois. Is that Dr. Francois?
Okay. Yeah, it's me.
You can't
Then it's
see.
from my end.
No,
Mm-hmm.
me too, I can't see the screen though.
Oh my God.
Since I can't see any screen, even when you said this is the diagram of something, something.
Why are you guys not telling me? You guys cannot see my screen, and all this recording I'm doing, I'm not supposed to be recording anything. That's what it means now. Because it's the recording that we are going to show people. You guys did not tell me, and I'm not happy about this.
Sorry. I just joined and I realized there was no
Sorry,
screen.
I thought it was my network. My network has been having issues since, so I thought it was my network.
I even had to text Dr. Zuliat and Toby that was happening. That is in my network.
Dr. Oluwaseola, if you have mentioned it on this page instead of testing,
So sorry.
I have to cancel what I'm recording because I've done nothing. That's what it means.